Good morning, everyone. It's 9 o'clock. Welcome to the Telehealth at the Crossroads. Thank you, everyone, for joining us today in our annual Telehealth at the Crossroads webinar workshop. We will talk about Crossroads. It is a point where a crucial decision is to be made that will have a far-reaching consequences. That's the definition of Crossroads. And right now, no one can argue that telehealth is truly at the crossroads. Early adopters of telehealth had seen its potential as a solution to provide adequate healthcare where there is none. But it took the COVID pandemic for most of us to recognize the benefits of telehealth in the field of medicine and to society as a whole. Still, there are a lot of skeptics and people who are just slow to adopt to technological changes and innovation that promote the greater good. And there's a concern that interest in telemedicine will peter out once COVID restriction is up. We out of the vanguard mustn't let that happen. Rather than allowing things to revert to the old way, we must rev up the promotion of telehealth and make it not just an alternative back road of delivering healthcare, but as a superhighway, an autobahn to healthcare, to use that metaphor. I think we should continue building this new road. Moving forward, we have and will continue to encounter obstacles to our path, such as regulatory barriers, poor infrastructures, platform issues, poor planning, and lack of training. But I think that TEXLA, TRC, HRSA, the National Consortium of Telehealth Resource Center, AAMC, and many other organizations, and people like us here that are coming on board and are committed on investing their time, money, and effort in building this superhighway. That is a vision for telemedicine in the future. We are fortunate to have expert speakers today, practitioners, lawyers, providers, managers, health insurance specialists like Robin, Monica, Kyle, Carmen, Katie, Danae, and Cameron, who will discuss the evolution of telemedicine, legal and regulatory knowledge, billing and reimbursement, adoption and practice of telemedicine and teleeducation. These are the variety of topics and specialties in the exciting field of telemedicine, specifically focused on our region here in Texas, Louisiana area. We are hoping that you will enjoy and learn from today's webinar. I'd just like to mention that TEXLA is a HRSA-funded telehealth resource center. We are a proud member of the National Consortium, which is composed of 12 regional TRCs and 2 National Resource Center, TTAC and the Connected Health Policy Center. We are also supported by Texas Tech University Health Sciences Center, Well-Ahead Louisiana, and of course HRSA, Health Resources and Services Administration, and we would like to thank them for their support. Just a little bit of a housekeeping. Make sure you keep yourself muted and unmute on demand. There will be a designated time for questions. Use the chat functions for questions or requests. And by the way, in order to claim your CME units, and we are giving about 6.5 hours of credit, kindly log on in my portal at TTUHSC CME website, which is seen there, and you will see them in your chat box. And don't forget to complete your survey to obtain the CME credits. Kindly look at the chat box for the link. Again, thank you very much for your attendance. I am looking forward on a robust and problem-solving discussion. But before proceeding, I would like to personally thank the 2 Lauras, Kelly, Cameron, Yogis, Jill, Miguel, Deborah, Lisa, Francis, Max, Sharon, Jimmy, and Cameron who organized this webinar, and to Dean Burke and President Lori Rice Spearman and Dr. Billy Phillips for all the support. Thank you very much and enjoy the webinar.
Good morning, everyone. My name is Cameron Onks. I'm Director for Innovations in Health Technology with Texas Tech University Health Science Center's Department of Rural Health. This morning, we'll be beginning with a discussion about telehealth evolution in Texas and Louisiana, brought to us by Robin Gelberd. And Robin is the president of Fair Health. Fair Health is a national independent nonprofit organization with the mission of bringing transparency to healthcare costs and health insurance information. Fair Health possesses the nation's largest collection of private healthcare claims data, which includes over 34 billion claims records and is growing at a rate of over 2 billion claims records per year. Certified by the Centers for Medicare and Medicaid Services as a national qualified entity, Fair Health also receives data representing the experience of all individuals enrolled in the traditional Medicare Parts A, B, and D. Fair Health includes among the private claims data in its database, data on Medicare Advantage enrollees. Fair Health licenses data and data products to businesses, hospitals, and healthcare systems, government agencies, and researchers. The company also uses its database to power a free, award-winning website that enables consumers to estimate and plan for their healthcare expenditures, as well as learn more about the healthcare reimbursement process. Robin is nationally recognized for healthcare policy, data, and transparency, and is a recipient of the 2016 DIG Benefits Technology Innovator Award. She's been invited to speak to organizations across the country on topics of critical importance to employers, employees, healthcare professionals and institutions, health plans, third-party administrators, consultants, researchers, and other stakeholders. She's also published numerous articles on topics such as data analytics and quality, healthcare cost transparency, and consumer engagement and protection, among many others. Prior to being recruited as president of Fair Health, Robin served for 8 years as general counsel of the Medical Research Foundation, comprising approximately 30 premier academic medical centers, hospitals, and research institutions in New York. Before becoming at a New York City law firm representing a broad array of healthcare-based clients, and before that, worked as a litigation and corporate associate in the international law firm Morrison and Forster. She began her legal career as a federal appellate law clerk to the Honorable Francis D. Murnaghan from the Appellate Court of the Fourth Circuit. So we're very excited to have Robin. I have seen portions of this presentation myself, and I can say it's very informative. And so if you all would, please welcome her as we speak.
Thank you. Thank you for that introduction. As mentioned, my name is Robin Gilbert, the president of Fair Health, and I'm delighted to be presenting to you today. In today's session, we will review the rapid expansion of telehealth utilization in 2020 and how it underwent changes throughout the COVID-19 pandemic. We will evaluate state, regional, and national trends in telehealth utilization, as well as costs for these services to see how this venue of care is continuing to evolve. For those less familiar with Fair Health, we are a national independent not-for-profit organization established to bring fairness and integrity to health insurance information. We, in effect, were created out of a national hunger for a standardized, comprehensive, and trusted data source to help all stakeholders exhale and have confidence in the information presented. We meet that need by having the largest collection of private insurance claims in the country and by being prudent stewards of that data. We now have over 34 billion private insurance claims from 2002 to the present. We receive over 2 billion new claims each year. The data are organized into 493 discrete geographic areas, or geozips, to help capture the relevant healthcare market. Such markets tend to track with the first 3 digits of a zip code. Our independence coupled with the breadth of the data collection and the robust auditing and validation methods we use, helps engender trust in the data and in turn, trust in the institutions using our data. Apart from our commercial data collection, we are certified by CMS as a national qualified entity and thus entrusted with the entire collection of Parts A, B, and D Medicare data set for all 50 states dating back to 2013. Currently, that accounts for approximately 37 billion Medicare claims that are housed separately from our commercial data. Many federal agencies and officials have reached out to Fair Health for assistance with various programs and initiatives. For example, we provide data to the Bureau of Labor Statistics to assist with their development of monthly medical indices. We also have served as a primary data source for GAO reports. We likewise serve as an approved source for MedPAC reports to Congress, demonstrating variation between the commercial and Medicare programs. We also provide data to federal agencies on a wide range of topics ranging from Lyme and other tick-borne diseases to food allergies and the opioid epidemic. We have also been turned to as a trusted source of telehealth data by the Office for the Advancement of Telehealth within the Health Resources and Services Administration. States also turn to Fair Health data for a wide variety of initiatives and official programs. For example, we serve as the official data source for workers' comp fee schedules, surprise billing solutions like in Texas, dispute resolution programs, fee schedules for state government employees, as well as benchmarks for specialized programs. Also, we serve as a quasi-all-payer claims database for states that do not have the budgetary wherewithal to establish their own APCD or the ability to create a self-sustaining APCD. Instead, states turn to Fair Health to get the benefit of analytics regarding their state's healthcare profile, and even more, they can evaluate their states against neighboring or like states, since we are more like a national quasi-APCD and have statistically significant data for all 50 states. Given the comprehensive collection of telehealth data in our repository, Fair Health began tracking the growth of telehealth long before its rapid expansion during the COVID-19 pandemic. In July 2019, we released a white paper on the emergence and contours of the telehealth landscape. This white paper caught the attention of Dr. William England, the director of the Office for the Advancement of Telehealth, who invited Fair Health to address FedTel at one of their bi-monthly web meetings. We had the pleasure of presenting to them an examination of telehealth services and costs at state and national levels. Once the pandemic hit our shores, Fair Health determined to once again tap into our extensive telehealth data collection and provide a clear window into this evolving venue of care. Toward that end, we launched the monthly Telehealth Regional Tracker, a free interactive feature on our corporate website that uses Fair Health data to provide insights into the month-by-month evolution of telehealth in every region of the country. This tracker compares a month in 2020 with its corresponding month in 2019 to show the dynamic changes in utilization associated with virtual visits before and after the onset of the pandemic. A year after launching the monthly Telehealth Regional Tracker, Fair Health enhanced the tool to offer additional insights into telehealth evolution. Rather than comparing the same month across years, 2019 versus 2020, the updated tracker offers a month-to-month comparison of telehealth's continued evolution. The data fields evaluated in the new tracker include telehealth volume of claim lines, top procedure codes by utilization, top diagnoses, and top mental health diagnoses. The new month-to-month tracker helps stakeholders obtain a better understanding of whether the increases in telehealth utilization during the surging months of the pandemic have continued, plateaued, changed in substance, or decreased as we continue to move to a post-pandemic environment. The next several slides provide some samples of data from our telehealth tracker. As you look at the next slides, please note that when there is a commonality between the procedures or diagnoses, as the case may be, the same color is used to reflect those same procedures or diagnostic codes. Here we are reviewing the top telehealth procedure codes in the South starting in January 2020. In January, the services most commonly performed via telehealth were telephone visits of varying lengths, new patient visits, and evaluation and management services for new and established patients. By April, however, when we were experiencing the first wave of the COVID-19 pandemic, established evaluation and management services became more frequent, and we began to see psychotherapy visits as well. CPT code 99441, which is a 5 to 10 minute telephone visit, was a top 5 procedure code in the South throughout the entirety of 2020, though it fell from its first to fourth in the ranking. In the months following April, CPT code 90834, a 45-minute psychotherapy visit, replaced the 11 to 20-minute telephone service for the 5th most common telehealth procedure. Trends in the South were similar to those in the nation as a whole. In January, however, we see that patient self-management and education was the 2nd most common telehealth procedure, though it did not appear among the rankings in the South. In the following months, evaluation and management services and psychotherapy visits were the most common procedure codes conducted via telehealth, while telephone services of varying lengths followed closely behind. It should be noted that 45-minute psychotherapy visits climbed up the national rankings by April, but it was not a top procedure code in the South until later in the year. Here, we are reviewing the top telehealth procedure codes in the South so far in 2021. As you can see, psychotherapy visits via telehealth continue to grow in the rankings in the South, showing a persistent demand for mental health services throughout the pandemic and after. 45-minute psychotherapy visits moved from 5th to 4th in the ranking of top procedure codes by February. And in March, 60-minute psychotherapy visits became the most common service conducted via telehealth. Evaluation and management services and telephone visits continue to rank among the top procedure codes, though they have been dropping as in-person visits have become more common. In April, longer telephone services of 21 to 30 minutes replaced shorter telephone visits of 5 to 10 minutes as the 5th most common telehealth procedure code. Telehealth psychotherapy visits rose even higher on the national scale during this timeframe. In January 2021, for the first time since Fair Health began its telehealth tracker, a 60-minute psychotherapy visit became the most common telehealth procedure nationally. It has maintained that rank throughout the year so far. Whereas telephone visits prevailed as one of the top procedure codes in the South, they fell from the national ranking by March. As you could see, telephone visits, which were consistently the 5th most common telehealth service performed nationally in 2020, were replaced by CPT code 90833 in March and April, which is a psychotherapy visit performed with an evaluation and management service. Now let's move on to the top 5 telehealth diagnoses in 2020. In the South, mental health conditions was the 2nd most frequent telehealth diagnosis at the beginning of the year, following acute respiratory diseases and infections. By April, mental health conditions became the most common telehealth diagnosis, with its share of telehealth claim lines growing from 11% to 26.9%. Its distribution continued to grow throughout the year. Acute respiratory diseases and infections was the most common telehealth diagnosis in January, but fell in the ranking in the following months, though it remained among the top 5. Joint soft tissue diseases and issues also became a frequent diagnosis via telehealth throughout the year. Developmental disorders and hypertension made appearances among the top 5 telehealth diagnoses in April 2020 and thereafter, suggesting that telehealth was being used for conditions not treated via telehealth before the pandemic. By December, COVID-19 and exposure to communicable diseases were among the top 5 telehealth diagnoses. This was likely related to the holiday surge in COVID-19 cases as patients reached out to providers via telehealth out of concern they had been exposed to the virus and or had contracted it. The trends in the South generally align with those seen nationally, although mental health conditions appeared as the most common diagnosis nationally at the beginning of the year. Mental health conditions rose as a share of all telehealth diagnoses throughout the year, although decreased slightly by December. Again, we see variation in the top telehealth diagnoses nationally in 2020, which is consistent with a trend toward the use of telehealth to treat a wider variety of conditions. And in December, COVID-19, for the first time, became one of the top 5 telehealth diagnoses nationally. In the first 4 months of 2021, mental health conditions continued to be the #1 telehealth diagnosis in the South, and its share of telehealth claim lines grew month over month. By April, claims related to mental health conditions accounted for over 50% of all telehealth diagnoses. Although COVID-19 was the 3rd most common telehealth diagnosis in January, it fell from the rankings by February. This change may have been related to the national drop in COVID-19 cases reported by the CDC that month. Acute respiratory diseases and infections, joint soft tissue diseases, and developmental disorders all remained on the list of the top 5 telehealth diagnoses through April. Although hypertension ranked among the top telehealth diagnoses in January and February, it disappeared from the rankings in March and was replaced by Encounter for examination. We see similar trends at the national level so far in 2021. As we saw in the South, mental health conditions continued to become a larger portion of telehealth diagnoses in the first 4 months of the year, and COVID-19 and hypertension appeared or disappeared from the top rankings after January and February. General signs and symptoms ranked among the top diagnoses in March and April, a condition that was absent from the list for the South. This could be a result of increased social interactions among vaccinated people, potentially without masks, which may yield more normal course illnesses, such as fevers. Now that we have covered the top procedure codes and diagnoses, let's review how telehealth usage as a percentage of all medical claim lines changed over the past few years. As you could see, telehealth claim lines were relatively low in 2019, comprising less than 1% of medical claim lines in Louisiana, Texas, the South, and the nation overall. In 2020, we see telehealth claim lines increase in all of these geographic areas. In Louisiana, telehealth accounted for 2.6% of all medical claim lines. In Texas, 4.1%. In the South, 3.5%, and in the nation, approximately 5%. It should be noted that these percentages are inclusive of all months in 2020. And as such, if we were to look at a month-by-month view, the percentages would be different as the pandemic carried on. These percentages indicate that telehealth was used less frequently in the South than it was in the rest of the nation. Indeed, our telehealth tracker found that the South experienced the smallest growth in telehealth utilization throughout 2020. In the first 4 months of 2021, we see that telehealth usage is higher in Texas, the South, and the nation than it was in 2020. In Louisiana, however, telehealth claim lines fell from 2.6% of all medical claim lines in 2020 to 2.05 in 2021. Although not indicated on this slide, it should be noted that our telehealth tracker is reporting month-over-month decreases in telehealth utilization in 2021 throughout the nation. Let's turn to the age and gender distribution of telehealth utilization. In Louisiana, telehealth was most commonly used among 36 to 50-year-olds. This age group comprised 27.7% of telehealth usage in the state, closely followed by surrounding age groups of 51 to 65-year-olds, who comprised 26.3%, and 21 to 35-year-olds, who made up 24.5% of the total distribution. We also found that telehealth usage was more prevalent among females than males. Louisiana had approximately 61.8% of telehealth services associated with female patients. The gender distribution of telehealth usage in Louisiana was similar to that in Texas. where we once again see female patients utilizing telehealth services more frequently than males. The age distribution, on the other hand, differs from what we saw in Louisiana. We see that the percent of telehealth claim lines is almost evenly distributed among the age groups through 50 years of age, with the pediatric population accounting for the greatest share. Individuals 51 to 65 made up just shy of 21% of the distribution, and those aged 65 and older made up the smallest share of telehealth claim lines at 3.2% of the distribution. This share was smaller than what was seen in Louisiana, where those aged 65 and over comprised 7.7% of telehealth claim lines. Nationally, the age distribution of telehealth claim lines again differs from what we saw in Texas. While the pediatric population comprises the greatest share of claim lines and the oldest age group accounts for the smallest share, the 0 to 20-year-olds make up almost 30% of the total distribution, and the other age groups comprise less overall than what was seen in Texas. Telehealth claim lines for females nationally are slightly less than what was seen in the Louisiana and Texas data, comprising 60.2% of the distribution compared to 61.8% and 61.5% respectively. This disproportionate share with respect to females is consistent with the findings of other researchers that women are more likely than men to visit physicians and make use of healthcare services. Our focus on telehealth expansion brought to our attention the growing number of claims for mental health conditions during the pandemic, which is why we included top mental health diagnoses in our updated telehealth tracker. Here we are reviewing the top mental health diagnoses in Louisiana in the first 4 months of 2021. Generalized anxiety disorder was the #1 mental health diagnosis in January through March, but it was replaced by major depressive disorder in April. The differential between the two conditions, however, is not significant, as anxiety comprised 24% of all mental health telehealth claim lines in April, and depression made up approximately 25%. In Texas, major depressive disorder consistently accounted for a greater share of telehealth mental claim lines than it did in Louisiana, and was the #1 mental health condition each month tracked in 2021. Texas also had a greater distribution of services associated with adjustment disorders, making up roughly 22% of mental health diagnoses, compared to between 16 and 18% of diagnoses in Louisiana. In general, the state distributions align with what was seen in the nation overall. In these charts, however, we see a greater distinction between the share of generalized anxiety disorder diagnoses and major depressive disorder diagnoses, with anxiety comprising 28% of mental health telehealth diagnoses and depression comprising 23%. Adjustment disorders, ADHD, and bipolar disorder rounded out the top 5, exhibiting little fluctuation in the distribution of claim lines from January to April. Now let's look more closely at the distribution of telehealth and office visits for mental health services. Here we are reviewing the venues for mental health treatment in Louisiana throughout 2020 for individuals ages 13 to 18 years, an age group whose mental health was particularly impacted by the COVID-19 pandemic. In January and February 2020, prior to the spring wave of the pandemic, mental health services were overwhelmingly rendered in an office setting. In March and April, when patients avoided in-person care for fear of infection with COVID-19, telehealth increased as a venue of care for mental health conditions. In April, telehealth accounted for 45.1% of mental health services compared to 54.9% for offices. This change persisted through the rest of the year, with telehealth steadily capturing between about 36 and 38% of mental health services from April to December. When we look at mental health services for all ages and their treatment venues in the state of Louisiana, mental health treatment via telehealth did not persist as it did among the younger age groups. In April, telehealth nearly surpassed the office as the preferred setting for mental health services, comprising 47.2% of services while 53.8% of services were rendered in an office. Between July and December, however, telehealth utilization for mental health treatment declined. By the end of the year, 75.7% of mental health conditions were treated in an office setting, while only 24.3% were treated via telehealth. Similar to Louisiana, we see a shift in the venues used to treat young people's mental health conditions in Texas. Although nearly 100% of this population's mental health treatment took place in an office setting in January and February, by April, almost 46% of these services were associated with telehealth. Once again, we see a continuing trend of telehealth use, with telehealth comprising between 35 and 40% of all mental health visits. Across all age groups in Texas, we see an increase in telehealth utilization for mental health services at the start of the pandemic, with about 50% of April services being performed in both venues. Similar to what was seen in Louisiana, mental health services via telehealth decreased more across all age groups than it did for the younger age cohort, comprising between 22 and 24% in the last 3 months of the year. When reviewing the distribution of telehealth and office visits for mental health services at the national level, we see that telehealth actually outdistanced an in-office setting for mental health treatment among 13 to 18-year-olds. In April, telehealth surpassed the office as the preferred setting for mental health treatment in this age group, accounting for 69% of mental health services compared to 30% for offices. Telehealth remained as the primary mode of treatment through December, when it accounted for almost 72% of mental health services compared to approximately 28% for offices. This distribution, while persistent, was not particularly stable, with telehealth comprising between 55 and 72% of mental health services between July and December, compared to a steadier distribution seen in Texas and Louisiana. Similar to the 13 to 18-year-old age group, telehealth surpassed the office as the preferred setting for mental health treatment across all age groups in April, when it accounted for nearly 65.7% of mental health services. From June through October 2020, telehealth remained as the primary treatment method, but dipped below 60% of all mental health services. By November, however, mental health treatment via telehealth was on the rise again, accounting for nearly 62% of mental health services compared to 37% for offices. In December, telehealth climbed even higher to 70.1% of mental health services. This surge from November to December is likely a result of the increases in COVID-19 cases due to holiday gatherings and travel. Asynchronous telehealth, which involves telehealth services that are not conducted in real time, also experienced growth during the pandemic. In both the South and the nation overall, hypertension was the most common condition treated via asynchronous telehealth. This treatment might include a patient taking a blood pressure reading at home and electronically transmitting the results to their provider for evaluation. Sleep disorders, mental health conditions, and diabetes also appeared in the top 5 diagnoses in both areas. In order to help stakeholders better understand the maximum amounts payers allow for reimbursement of provider charges for telehealth services, Fair Health is creating FH Allowed Telehealth, a benchmark product documenting an array of values for approximately 400 telehealth specific codes. FH Allowed Telehealth will serve as a companion product to our charge benchmark, which values telehealth services. The new Allowed product, which will be launched in December 2021, will include the mean, mode, and 50th to 95th percentiles of allowed values for each code in all 493 geozips. In the next few slides, we'll use data pulled from these benchmark products to review the charge and allowed values for services rendered in an office versus telehealth setting. As you may know, the cost for services performed in a telehealth setting versus a non-telehealth setting can vary by both location and individual service. For example, when reviewing CPT code 90834, which is a 45-minute psychotherapy visit in Louisiana, the average charge and allowed amounts are slightly higher in a telehealth setting than they are in an office setting. In New Orleans, the average charge and estimated allowed amounts for the service in an in-person venue are $141 and $89 respectively. When this service is conducted via telehealth, the charge and estimated allowed amounts are higher at $151 and $93. Here, we are reviewing the costs associated with CPT code 90837, a 60-minute psychotherapy visit in different locations throughout Louisiana. Unlike 90834 and the previous areas in Louisiana, the values for CPT code 90837 are not consistently higher in a telehealth setting. As you can see, the estimated average allowed values for the service are somewhat lower in a telehealth setting than they are in a non-telehealth setting across all 3 locations. In the state overall, for example, the telehealth allowed amount is $79, while the in-person allowed amount is $81. However, the charge value for this service in Slidell and Hammond, Louisiana, is just about the same between the telehealth setting and the in-person setting, with a $1 differential. CPT code 99213, which is an established patient office visit that can be billed in an office or via electronic or telephonic methods, also experiences variation between telehealth and non-telehealth venues. We see here that telehealth costs for this service generally run higher than in-office costs, with the exception of the charge value in Chalmette and Laplace, Louisiana, where they are roughly the same. CPT code 99214, which is a longer evaluation and management service, is typically more costly when performed in an office setting. We see the greatest disparity in New Orleans. The average charge value for CPT code 99214 when billed in an in-person setting is $267, while the telehealth charge value is lower at $228. The estimated allowed amounts in New Orleans have a similar disparity, with an in-office average amount of $138 compared to the telehealth amount of $119. Now let's look at values for those same codes in Texas. If we look at the estimated average allowed amounts for a 45-minute psychotherapy visit in Texas, we see that the telehealth value is lower than the in-person value, which is the opposite of what we saw in Louisiana. In Houston, for example, the allowed amount is $97 for an in-person visit, while a telehealth visit is $86. Except for Dallas, the average charge amounts in Texas are also generally higher in an office venue than they are in a telehealth setting. The costs for a 60-minute psychotherapy visit also vary across locations. The average telehealth values are higher than in-office values in Athens and Tyler, Texas, as well as the state overall. They are somewhat lower in Galveston and Pasadena, Texas, though marginally. If we look at the average charge amounts for this service in Athens and Tyler, we see that the telehealth value is $153, while the in-person value is $145, and the estimated allowed amounts are $92 and $95 respectively. In Galveston and Pasadena, on the other hand, the average bill charge for this service is $133 in a telehealth setting and $124 in an office setting, while the estimated allowed amounts are different by $2 in favor of the office visit. As we saw in Louisiana, telehealth costs for a 20 to 29-minute evaluation and management service typically run higher than in-office costs in Texas as well. In the Corpus Christi, Portland, Texas region, there is a larger difference than in the other areas, with the charge differential being $10 and an estimated allowed amount difference of roughly $8. In Brownfield, Lubbock, the difference is smaller at approximately $2 to $3. A longer evaluation and management visit experiences minimal variation in values between telehealth and non-telehealth venues, only differing by $1 to $5. Finally, I wanted to close with a few takeaways from our monthly telehealth regional tracker to date in 2021. Although telehealth expanded dramatically in 2020, telehealth claim lines have declined most months in 2021 throughout the nation. From January to April 2021, mental health conditions were the top telehealth diagnoses in every region of the country, suggesting that telehealth may continue to serve as a preferred setting for mental health treatment. In February 2021, developmental disorders joined the top 5 telehealth diagnoses in the South. COVID-19 dropped from the list of top telehealth diagnoses in every region of the country in February 2021 as vaccination rates began to rise. And nationally and in the South, psychotherapeutic psychiatric codes replaced or outranked evaluation and management codes in the list of top 5 telehealth procedure codes in March 2021. In April 2021, the South experienced the greatest decline in telehealth utilization out of all 4 census regions in the nation. I want to thank you for this opportunity to share our telehealth data and resources, and I'm happy to take your questions.
Thank you very much, Robin. If you have questions, please feel free to either raise your hand or unmute, and we'll take them as they come up. Mr. Leah? Benjamin?
Hi, this is Ben Leah. I was just wondering, do you have any like quality or satisfaction data to go with all this claims data?
I'm so glad you asked that question, because that's going to be, I think, the next frontier of telehealth research. Right now, there's been intense interest in utilization and volumes of services and so forth. What we're next planning to do, and we've done this with other venues of care, given that our repository has a large swath, millions and millions of patients de-identified, but longitudinally trackable, we are going to track patients accessing telehealth for different types of services, seeing to what extent their diagnoses increase in terms of severity, to what extent they then resort to an in-office setting anyway, to what extent there's duplication. There are a lot of value questions to be answered. And I think there's a real hunger for that as plans are considering how to integrate this into their plan design and integrate telehealth providers into their provider networks. And as providers are thinking about how to continue to communicate and make sure record keeping is really robust so that they're part of a continuum of care. And it will also inform at the Medicare level as they're continuing at the CMS level, thinking about Medicare policy with respect to telehealth. So thank you for that question. We've already designed a study toward that end and are seeking funding for that particular type of window into telehealth services.
Dr. Santos?
Robin Gilbert, thank you very much for a wonderful presentation, and congratulations to Fair Health, for the excellent work and for giving us all this valuable information that I think is necessary for current problem as well as addressing future problem. Based on your assessment, are we able to cope up, with the problem of mental health conditions, and what do you think we could do? There's a lot of federally qualified health centers here. What can we do on the local level to ameliorate this problem? And my last question is: are we measuring remote patient monitoring as well in this in your tracker?
Yes. So thank you very much. In terms of mental health conditions, we are actually doing a specific study for one researcher involving federal qualified health centers. There's also a real interest in looking at how group therapy can be taught and made more available, even through a telehealth setting, to defray costs for those people who are having difficulty paying for the service. I think one of the positive outcomes that we're seeing in increasing use of telehealth for mental health conditions, people are seeking the care. What we have found fascinating is the incredible transference from in-office services to mental health beginning in March and April of 2020. It was really amazing how the patient population as well as the provider community adapted to the lockdowns and many of the in-office visits, and people recognizing the need for care have sought have sought out those services and continue to seek out those services. With respect to remote monitoring, we are tracking that. That has not factored into the tracker per se because it is not at the level of volume. It's still a growing use of those technologies. Interestingly, though, mental health conditions are starting to factor into the asynchronous column where you have therapists having patients submit, for example, diary entries or journal entries or other kinds of informed communications related to their condition that the therapist can review maybe prior to an in-live session. So it is interesting how it's moving from sort of cardiac monitoring, pulmonary monitoring, dermatology uses to the mental health setting as well. So I think there's just a general level of frenetic activity and creativity in trying to meet what seem to be really persistent mental health care needs during this pandemic and beyond.
Thank you very much. And a follow-up question, I look quickly, for the CPT code for the group therapy, it's 90853. Do you could currently bill for that? And how do you build that? Do you build them for, because you are, I think, allowed up to 12 participants for group psychotherapy, do you bill individually those 12 participants? Or how do you do that?
Well, there are specific coding guidelines for providers if they're dealing with a group session, and I'm sure they would just adhere to those standard guidelines. There's a code that would identify that it's a group service. So I'm sure there's an enhanced level of reimbursement versus sort of an individual one-on-one kind of service.
Looks like we have another question from Dr. Phillips.
Thank you. Oh, I'm muted, sorry. Can you hear me at all?
Yes,
Yes,
I
sir,
can.
we hear you.
Okay. Wonderful presentation. Thank you so much, Robin, for the excellent information. It's just really a comment. Some years ago, our team developed a program called Twitter, Telemedicine Wellness Intervention Triage and Referral. We used it in schools in West Texas to deliver telemental health services to support counselors and other people who were working with troubled youth. And I think as you presented the Texas data, it made me realize or suggested that perhaps we had a more transformative effect on mental health than we thought. It was taken statewide 2 years ago as a program endorsed by 9 academic health science centers and serving schools around about them. And through the Texas Child Mental Health Consortium. And I think we're seeing that in your data. And that just makes the case of the low-hanging fruit for telemental health services. And I think what COVID did is it was sort of like an accelerator of that adoption. And so I hope we continue those kind of innovations. The quality issue is a very important one. The telehealth monitoring biometrics is another one. Both of these have been mentioned this morning. And I really do think we have a lot of research that we need to do in that venue. I wondered if you would just comment on the directionality of that kind of research. And thank you.
Sure, no, thank you for your comment and question. So we're really privileged to be sitting on 34 billion records. We play roles in different ways at Fair Health. So in sometimes we're the canary in the coal mine, right? We can see trends emerging, clinical issues of concern emerging that we can alert specific jurisdictions to or the nation as a whole. And we did that with the opioid crisis, and we've done that in other areas, whether it's Lyme and tick-borne diseases and certain cancers and so forth. But then we can do, as you're suggesting, we can confirm or evaluate the impact of particular statutes, regulations, or public health interventions. And I think you're right to take from the data the suggestion that there has been some impact in that very creative reform that was introduced. And those are the types of things we continue to monitor and are asked to do by whether it's state officials, federal officials, or public health experts and other stakeholders. And it's in a sense, we have this like ocean of claims, and we take people out on this glass bottom boat to see what's really happening in those waters. And it's because we have very detailed information on the claim, like place of service, like specialty, procedure code, diagnostic code, et cetera, we can really discern so many interesting facts from those claims itself. So for example, school-based services have its own point of service or code. There are ways in which to track back, like retail clinics, for example. Texas has been very, has sort of one of the leaders in terms of broadening the use of retail clinics to really become part of the primary care front lines, more so than some of the other states, expanding, having retail clinics have 45-minute office visits, whereas before they used to be used for flu shots. So it is interesting to see how venues of care are evolving, like telehealth, like retail clinics, and also how different kinds of trends are emerging with respect to the way people access care at those different venues.
So we have time for just a few more questions. Again, if you would either type them into the chat or raise your hand and we'll be happy to let you ask. Not seeing anything. I'd like to go ahead and thank you very much, Robin, for your presentation. The first time that I saw it, I thought it was excellent, and we were very happy to welcome you here to share it with others. I think it's important, and it really does provide, like you said, that glass bottom boat view for what can be an overwhelming amount of information, to give some transparency to what's actually happening and then pull the trends out and understand how we can better address some of the trends that we're seeing. So thank you very much for your presentation.
My pleasure. Thank you for the invitation.
Of course.
Bye-bye.